what a beautiful evening to have Dr. Sheikh with us, and who will be taking us on information on diabetes. What are the recent update on diabetes? A scholar in herself, uh, and Dr. Madhura from MHL. She's placed at the Global Hospital. Under the corporate social responsibility, I welcome Dr. Sheikh because it's not only about this her social responsibility, because she wants to give information on this diabetes, and we all know that diabetes is progressing so apparently in our country. So thank you, Dr. Sheikh, for taking out your time on under the social responsibility, because you really mean for the community, and Dr. Madhura for agreeing to be the moderator. All the best for this session. Thank you so much. Over to you, Dr. Madhura.
Good evening, everyone. I'm Dr. Madhura Jogwar, Chief of Lab Metropolis Healthcare Limited at Gleneagles Hospital, Mumbai. I welcome all of you. Today, we have a very interesting topic pertaining to the recent updates in diabetes. Diabetes, as we all know, is a global health concern, and its prevalence has only been increasing over decades. India itself has the highest number of people who are living with diabetes. According to the International Diabetes Federation, about 90 million people in Southeast Asia have diabetes, and the India accounts for a significant portion of this number. To enlighten us all about such an important topic, today we have our esteemed speaker, Dr. Shaila Sheikh. I would like to introduce you, ma'am. She's a consultant endocrinologist at Sethi Hospital and HN Reliance Hospital, Mumbai. Madam has been a principal investigator in multiple international clinical trials. She's a member of Executive Committee, Endocrine Society of India from 2021 to 2024. She has been a treasurer of ESI Maharashtra from the year 2019 to 2022. She's been awarded amongst the top doctors of Mumbai by the TOI group from the year 2017 to 2023. She's received Hamdan bin Rashid Al Makhoum Foundation for Medical and Educational Sciences Award for her research in Ramadan, which is very, very extensive and extremely interesting. She is the author of International Hajj and Diabetes Guidelines and IDF DAR Guidelines 2021. She has published many papers, review articles, and she is a speaker at national and international fora. On behalf of Metropolis, I welcome you, ma'am. I'm sure there is an academic feast to follow in coming 1 hour. I request the audiences to put any questions in the chat box, and we can have it at the end of the presentation. Over to you, ma'am.
Thanks, Madhura, for those very, very kind words. And a big thank you for making me a part of this fantastic initiative. So thanks to Dr. Shalini, thanks to Metropolis, and of course, thanks to Madhura. To be very honest, friends, I'm going to give you a very brief overview today about what exactly is happening as far as the field of diabetes is concerned. I may not be able to cover up everything, but I'm hoping that since I've been, what I've understood, that I am predominantly speaking to students who I believe we all learn from, because, you learn the maximum when you are a student, and actually learning never ends. So I'm as much of a student as any one of you all out there. I think it's very, very important that we at all points of time keep abreast of what is happening, what is new. And that's the reason I say the learning never ends. And that's the reason why we say that's the reason I actually want to thank each and every one of you who's logged in today and who's going to be with us over the next 1 hour. Madhura put it across to you very well. She told you something very, very pertinent, that India is unfortunately the diabetes capital of the world. We are at all points of time hoping that we can change this, tag to maybe a tagline of India being the diabetes care capital of the world. But as of now, unfortunately, we are faced with a situation where we have significant numbers as far as diabetes is concerned. The numbers already have been told to you. And we, all of us, and when I say all of us, I mean it, irrespective of which field of branch of medicine you finally choose, which branch of medicine you decide you want to go into. It's very important that you know about diabetes, because irrespective, for example, you are a surgeon, you will still have to be looking after your patients who are living with diabetes. You're a physician, of course, you'll be looking after them. Even if you're a gynecologist, with the increasing incidence of GDM and pregestational diabetes, you will be having to look after patients who are living with diabetes. So, what has changed? Over the next half an hour, I'm going to try to discuss what has changed. Where are we today than what we were maybe a decade back, maybe 5 years back. I'm going to give you brief snapshots about what has actually changed as far as our outlook goes, as far as our diabetes care goes, as far as how would you approach a patient when a patient is sitting across to you in your busy consulting room. Now, when you look at conventionally, whenever we spoke about diabetes, what did you and me think about? What you and me thought about at all points of time, friends, was only their sugars. A decade back, or I would say even maybe 5 years back, most of the patients only checked their blood glucose fasting and PP. It was uncommon for patients even to check their average HbA1c, that is the glycosylated hemoglobin, which is a reflection of the 3 months average mean glucose control. Because the concept was you just need the sugars fine. Fortunately, we have evolved from that viewpoint. And the reason I'm saying we have evolved from that viewpoint, because we are now increasingly recognizing that diabetes is associated with a number of complications. And we now need to very proactively diagnose those complications. We need to very, very proactively treat those complications. And we need to, if possible, use disease modifying drugs, the drugs which actually are able to modify the risk of progression of these complications, be it your cardiovascular disease, be it your CKD, be it your heart failure, or be it even something as simple as retinopathy. Now, friends, why have we changed this? Where did this thought process change? This thought process changed because as more and more data came in, as more and more research came in, as more and more we started realizing that there are certain differences as far as management of patients is concerned. And when we started realizing that now you have molecules which can actually make a difference, you as a physician are not justified to use molecules which do not make a difference right at the beginning. And if you want to use the right molecule in the right patient, it is very important that you are able to diagnose the complication in hand. For example, if your patient has heart failure and your patient will not, and as we all know, your patient classically in a patient of diabetes, the symptoms are very different from what you would expect in a non-diabetic patient. Unless you diagnose heart failure, unless you diagnose a patient is having early diabetic nephropathy by doing a urine albumin creat ratio, unless you actually see a patient's EGFR, you are never going to be able to actually say this patient is having complications. And that's the reason it's very important that now when we look at our patients, now when we evaluate our patients of diabetes, we understand a very, very important fact that we need to now look at our patients from a completely different viewpoint. And when I say a different viewpoint, I mean we need to be able to evaluate our patients not only fasting PP and HbA1c, but we need to see our patients' evaluation as far as the kidney is concerned, EGFR and USCR. We need to know what is the patient's ejection fraction. So you definitely need an ECG and 2D echo in place. If the patient is, I am so sorry, but there's a little disturbance. 1 second. I'm so sorry. Apologies for the same. Very, very sorry. Can I continue, please?
Please continue, ma'am.
Yeah, sorry, once again.
No problem.
So we have moved from a point of complications. So that is where we reached as far as complications were concerned, friends. Now, are we still missing the boat? Very, very important question. Are we still not where we ought to be? And that is where, again, a thought process change happened. That yes, we are diagnosing a patient. Yes, we are looking at complications. Yes, we are trying our best to maybe prevent complications or treat complications. But why is this entire story? Can we do something beyond that? Can we make a difference as far as onset of these complications are concerned? And that's where, again, there's a change in thought process where your thought process moves to pathogenesis centric. At this point of time, you all must have heard about the ominous octet. When we are talking about the pathogenesis of diabetes, you all have heard about the ominous octet. I'm sure about that. Today, you're going to go and also search for what do you mean by the noxious nine? And I want you all to send us maybe a message saying, okay, what do I mean by noxious nine when I talk about pathogenesis? Because since we are students, I'm going to give you 2 or 3 questions to work on before we stop talking to each other. So what we realized is, friends, that now we are at a point of time where maybe we need to think about before the onset of diabetes, where can we make a difference? And that's where the entire thought process changed to whether it's the obesity, is it the insulin resistance, and do we now have molecules which can make a difference as far as that goes? And that is what is very, very interesting, because from a glucocentric approach, which was a downstream intervention, which you and me intervened when the patient already had an illness, when the patient already had a complication, we are moving upward. And when I say upward, upstream, means we are now going to try to treat our patients before they develop dysglycemia. We are going to try to treat them at pre-diabetic stage. You and me are going to hopefully make a difference just at the point of time when they're obese, when the patient has obstructive sleep apnea, MAFLD, osteoarthritis, dyslipidemia, hypertension, coronary artery disease. We don't want any of this. We want to be able to treat that dysfunctional adipose tissue. We want to be able to make a difference as far as that excess adipose tissue is concerned. I'm sure all of you all know about the ectopic fat hypothesis. That's one hypothesis which honestly fascinates me. And the reason it fascinates me because the ectopic fat hypothesis is actually a very simple hypothesis. If it simply says that if you have excess fat in your body, it is going to get deposited in your organs. Because your subcutaneous area is limited. Your fat after a certain point cannot get deposited in the subcutaneous area. So obesity beyond, like once you become overweight, I think even treating a patient by the time the patient becomes obese is a little too late. Treat the patient, talk to that patient when the patient is overweight, because that's where you will make a difference. That's where the dysfunctional adipose tissue, which has gone and actually got deposited in the liver, that adipose tissue, which is actually deposited in that epicardial vessel, that adipose tissue, which has actually gone and got deposited in your pancreas and your kidney. If you can make a difference as when the patient is overweight, that's when you would be actually able to make a difference as far as in everything which this slide shows. Because adipose tissue is not innocuous. It is not something which is very, very simple. Adipose tissue, mind you, causes inflammation, oxidative stress, insulin resistance, vascular dysfunction, results in neurohormonal activation, results in a whole load of things which you never realize is actually just as a result of that dysfunctional adipose tissue, which through the adipokines, through the cytokines, through the inflammatory factors, all those factors is going to actually create havoc all over. Doesn't it make sense then to treat that? You think it does? Let me know at some point of time whether you think it does. And why do we want this? Because we need treatment which is effective. We need to prevent morbidity. I don't want disability. You don't want distress. That, as we all know, yes, maybe we cannot make an obvious difference, but yes, what you can do is definitely, we know that diabetes reduces the lifespan. So you can at least offer the patient the normal lifespan. Any therapy, very important to minimize harm and burden of treatment. We all know the Hippocrates Oath. We all know that we do not wish harm. When you talk about efficacy, very important to reduce the waste and burden on the healthcare system. Most important, I always feel, is the last three things in this entire this. The first three is something which we all take for granted because we know we need to give safe treatment. We know we need to give efficient treatment. But do you and me give timely treatment? Do we reassess our patient? Do we always time it that, okay, in 3 months, if you're not at target, we will have to then go to the next dose? Or do we say, okay, it's okay. I guess you're doing pretty okay. I guess it's fine. Do we do that? Do you, as a clinician, ensure optimal care and outcomes for all the people that you are seeing in your busy OPDs? And I'm sure you all are seeing busy OPDs because you're in third year MBBS. And most importantly, how often do we high-handedly tell our patients, do this? How often do you ask your patient, is it possible? Is it doable? Do you have cost constraints? Do you have social constraints? Have you really understood what I have tried to tell you? We need to really work on that to be able to make a difference, friends, because that's where we will be able to make a difference. And that's where I like this entire concept of the CKM syndrome. This is as recent as 2023, as you can see in the reference. What do you mean by a CKM syndrome? By diagnosis, this sounds totally opposite to what I've just told you. When you read this syndrome, which I'm sure you're reading this slide, you look at it as a pathophysiological interaction. It's a systemic disorder. There are metabolic risk factors. There's CKD. There's cardiovascular system disease. There's going to be multi-organ dysfunction and adverse cardiovascular outcomes. So what am I trying to tell you? I told you the CKM syndrome, and this includes everything which I don't want in my patient. And I'm again reiterating, is the adiposity, which is the underlying issue. What I am telling you is that you can make a difference because this CKM syndrome has stages. Now, if you look at this slide, what you see is stage 0, where there are no risk factors whatsoever. And how can there be no risk factors? Do we really have no risk factors? Yes. Primordial prevention. When we talk about primordial prevention, we talk about preventing the onset of any kind of disease. Primordial prevention depends on life's essential 8. And these life's essential 8, which are very actually obvious from that figure out there, which includes everything that we talk when we talk about a healthy lifestyle. But still, you're going to write back to us and tell us what we mean by life's essential 8. One of the important parameters, which I just want to emphasize, because I'm sure the rest you know about, is apart from the ABC, that is the HbA1c, the blood pressure and the cholesterol, apart from that one, and the diet and exercise, of course, very important, friends, is sleep. Underestimated parameter of daily life at this point of time. We have become a race which believes that sleep is the most negotiable factor in your daily living. Everything else is in place, but how many hours do you actually sleep? Think about it today. Think about how many hours your patients are actually sleeping. The blue light, how much it has disrupted our lives. Next time you talk to a patient, try to understand when do they switch off their mobiles in the end of the day. Coming to stage 1, which is, as I said, the overweight or obese stage. Patients could have IGT, again a stage where you can make a difference. Stage 2 is a stage where most of us try to make a difference, where the patient already is going to have hypertension, the metabolic syndrome, dyslipidemia, diabetes, and moderate to high risk CKD. By stage 3, we are struggling. The reason I'm saying we're struggling, because we're struggling now to prevent complications, to prevent end-stage problems. This patient could have subclinical ASCVD, this patient could have subclinical heart failure, and finally you evolve to stage 4, where you have CHD, you have HF, you have peripheral artery disease, stroke, AFib, all these various parameters which you really do not want. So as I said, stage 0 we discussed, primarily seen in children, adolescents, and young adults, but it can be seen across the lifespan. Across the lifespan, if we really focus on primordial prevention throughout, which most of us don't. We know in Asians, when we talk about overweight, the BMI is reduced by 2 kgs per meter square, and that's the reason our upper limit of overweight is 23 kg per meter square. Our waist circumference again is lower in the Asians, 80 to 90 centimeters in women and men respectively. That would approximately be around 34 inches if I really put it across very, very briefly. And of course, you all know that an impaired glucose tolerance is a fasting glucose between 100 to 124, or an HbA1c between 5.7 and 6.4. These numbers which we take very, very lightly. And when I was talking about the altered fat topography, this is what I was talking about when I said that there would be increased pancreatic fat, which is going to contribute to the entire issue. Stage 2, as it is a stage which you and me are trained for. I'm sure you all are training for how do we treat hypertriglyceridemia, how do we treat hypertension, how do we treat the metabolic syndrome, diabetes, or CKD. All these are what you and me treat in our busy clinics. And what we need to understand again is all these factors are finally interrelated. You cannot afford any longer, friends, to treat in isolation. You need to be able to understand that pathophysiologically all these conditions are interrelated. And that's the reason finally you're going to end up with a situation of all the complications we spoke about unless you preempt them. Do a coronary artery calcification score. Check a CT angio to diagnose subclinical ASCVD. As I said, check your 10-year CVD risk. See what is your patient CKD score by the KDIGO classification, because those are the parameters which will help you actually diagnose whether your patient is going to subsequently land up with further problems. So how do we actually put this from the patient's perspective? Two very important issues we have. One, if you look at our goals, definitely prevent both acute as well as chronic complications. Definitely you want to optimize the quality of life. And for doing this, you need to know what are the key person characteristics. What are factors that impact the choice that you're going to make as far as therapy is concerned? Be it nephropathy, be it microvascular complications, be it macrovascular complications, be it other associated factors. Make a shared decision plan. Unless your patient in front understands and is part of the plan and agrees on the management plan, the implementation is always going to be a problem. And then you and me unfortunately, often then write on our papers, patient is non-compliant. Does the patient have a support system in plan? Is the patient really able to monitor? And last but not the least, review, talk, agree that yes, this is the best way forward as far as the patient is concerned. And that's when you'd be able to get all these parameters in place, be it glycemic management, be it weight management, be it CV risk factor management, or be it cardiorenal protection. So how would you do it, friends? Lifestyle, a topic by its own, so I won't get into the details of that. What I am going to be talking a little about is some of the medications and which other medications which you and me use nowadays in clinical practice. At this point of time, we've moved away from talking in terms of HbA1c. I told you that in the first slide. So when you are looking at patients, you are looking at patients who are high-risk individuals with type 2 diabetes. For example, if they have ASCVD, or they have indicators of high ASCVD, or they have heart failure, or they have CKD. In these situations, two drugs which have proven the mettle are SGLT2 inhibitors and GLP-1 receptor agonists. CKD, SGLT2 inhibitors definitely have an edge. For ASCVD or GLP-1 receptor agonists have an edge. And for heart failure, again, your SGLT2 inhibitors have an edge. What about weight and glycemic goals? For weight and glycemic goals, again, you have drugs which have a very high efficacy for weight loss. For example, semaglutide and tirzepatide. We have both available in our market at this point of time. I'm sure everybody has heard about tirzepatide. I mean, it's like the semaglutide and tirzepatide seem to have taken the imagination of people. Really, I mean, it's gone wild. And you have now patients telling you, okay, ma'am, can we possibly use these drugs? Dulaglutide, liraglutide, again efficacious for weight loss. Intermediate will be GLP-1 receptor agonists, and neutral will be metformin and DPP-4 inhibitors. What about glycemic goals? Again, when you look at glycemic goals, very high efficacy would be again your dulaglutide, sema, tirzepatide, and of course insulin. Another very important point I want to put across over here, insulin is a hormone, is a treatment just like any other hormone you use. And only just because it's an injectable drug, a lot of people have this mental block regarding it. But when you look at the basic definition of diabetes, we know, friends, diabetes is a disorder of insulin deficiency. Of course, in our type 2 diabetics, along with that, there is also insulin resistance. And for glucose lowering, as you would see further down the line, you have your GLP-1 receptor agonists, metformin, glitazones, which again, we do use SGLT2 inhibitors and SUs. So I've tried to put across in this slide in a very, very brief way, efficacy, weight, hypoglycemia, route of administration, cost, and which candidates would you really use this drug in. If you see metformin, for example, metformin is again a drug which acts very well on insulin resistance. Most of us use it in combination with another drug at diagnosis. We are no longer using molecules in isolation. We are using either fixed drug combinations, or we tend to use maybe molecules separately. But even at diagnosis, considering the fact that we have a huge amount of data regarding better durability of the molecule and better efficacy, and since drugs do not have a very high risk of hypoglycemia, we generally use drugs in combination at this point of time and not in isolation. As far as glucose efficacy again goes off, if you look at this entire column of glucose efficacy, other than DPP-4 inhibitors with the intermediate, all the other molecules do have a high efficacy as far as glucose reduction goes. Weight loss is seen only with SGLT2 inhibitors and GLP-1 receptor agonists, whereas GIP, GLP-1 receptor agonists show a very high weight loss. DPP-4 inhibitors and metformin are neutral as far as weight loss is concerned, but SUs and TZDs, the maximum weight gain, friends, is seen with TZDs. SUs, the newer SUs, if you use them intelligently, smartly, slowly, safely, they're pretty good molecules to use. Risk of hypoglycemia, again, nil as far as your metformin, SGLT2 inhibitors, GLP-1 receptor agonists, dual agonists, and DPP-4 inhibitors are concerned. Only SUs do have an increased risk of hypoglycemia. Route of administration, your GLP-1 receptor agonists and GIP-GLP are subcutaneous. You do have oral GLP-1 receptor agonists also. But as far as cost is concerned, as we all know, the GLP-1 receptor agonists, the cost is much higher than the other molecules out here. Ideal candidates, again, individualized therapy. When you have guidelines, they give you brief guidelines as to which candidate you can use. Whenever you're using a molecule, make it a habit to think about two things, friends. One, efficacy, and second, safety. Two very important things. And from the patient's viewpoint, of course, what would be the social implications like cost, availability, etc., etc. But as shown to you in the previous slide, at this point of time, we've already seen where SGLT2 inhibitors and GLP-1 receptor agonists can be used. But certain situations like older adults that require easy administration, very safe molecules, DPP-4 inhibitors are good molecules to go to. We are at this point of time blessed in our country because we do have generic molecules available, be it SGLT2 inhibitors or GLP-1 receptor agonists. And because you have generic molecules available, the cost factor which has been put up over here that with SUs and TZDs is really not that important at this point of time because you do have generic SGLT2 inhibitors and GLP-1 receptor agonists available to you. This is a little more expansive, when I've tried to put across to you the safety conditions mainly. For example, metformin can be used up to an EGFR of 30. Do not use with an EGFR of less than 30. SGLT2 inhibitors, be very careful with recurrent yeast infections or UTIs. Any kind of euglycemic decay, necrotizing fasciitis of perineum, though extremely rare, and volume depletion, be careful with these drugs. Stop these molecules at least 72 hours before any illness or before any surgery. If this patient is on associated diuretics, you need to assess volume status, blood pressure, and adjust the drug to be sure that the patient does not end up with any kind of hypotension. And of course, when you're using these drugs, always educate the patient. An educated patient regarding genitourinary infections is always a patient who will then not get worried, who will reach back to you saying that, yes, I have a significant infection and I need help with that. Otherwise, unnecessarily, this patient ends up really going across town thinking that, oh my God, how do I treat this? I really have a problem. And that could be associated because of diabetes also. GLP-1 receptor agonists, again, do not use with any kind of thyroid C-cell carcinoma. Ask the patient's history. Any pancreatitis, caution, to be used with caution. Retinopathy, gastroparesis, gallbladder and biliary disease, used with caution. DPP-4 inhibitors, good drugs to use, but efficacy-wise may be a little less efficacious compared to the other molecules, but very, very safe drugs to be used. And in some of these molecules can be used across the spectrum as far as renal function is concerned, whereas some molecules you'll be more careful. SUs, again, I believe that SUs are good molecules to be used. SUs can be used very, very safely and intelligently in our patients. And one of the most important side effects of hypoglycemia can be managed very well in our patients if you educate your patients regarding lifestyle. TZDs, though their common adverse events are edema and weight gain, again, very good insulin sensitizing agents. And mind you, the only drug which at this point of time, amongst all the other molecules, is approved in patients with MAFLD, where it shows benefits. Coming to the last 2 or 3 slides about monitoring, because I really won't be able to talk everything about monitoring. But when you are treating your patient, what are you going to look at? You're going to try to look at the patient being in range for at least more than 70% of the time. That is more than 16 hours, 48 minutes, 70 to 180 is what your target is by your CGM data. And which is the patient best suited for CGM? When you actually just don't understand what is happening often, your patient's HbA1c is different, fasting PP is different, patients with a monitor, it's totally different. That's the kind of patient you really need CGM. When the patient is not really tracking, patient is not interested, patient, I don't like monitoring with the glucometer, CGM is actually very, very helpful. Suppose this patient is having a history of hypoglycemia, worried about hypoglycemia, not sure whether the patient would have nighttime hypoglycemia, CGM would really help. And sometimes we are now using CGM even in patients without diabetes, pre-diabetic, to understand which foods are influencing which patient in which way, be it food, be it activity, be it stress or lifestyle. So if I summarize what I try to put across in the last half an hour to you friends, because I'm trying to keep time for question and answer so that we can really interact and talk to each other, and I can actually answer the queries you have. So I would request you, whichever query you have, if you don't want to put your name, just blindly send us a query. We will try our best to answer for you, so that when you log out of this meeting, we hope that we have managed to sort of stimulate that gray cell of yours to go and check and read more about diabetes and be better equipped to look after your people living with diabetes. So we spoke about the pathogenesis-centric approach. We went upstream. We spoke about how we need to make it holistic and individualized. We spoke about the CKM syndrome. And last but not the least, all this has to be individualized, because no two shoes are the same. The same glove does not fit different hands. And we do not have the same fingerprint for different patients. So look at the patient, understand the patient, have that important conversation, try to do your best as far as not only preventing complications are concerned, but preventing diabetes is concerned, so that, as I said in the beginning, we can convert to becoming the diabetes care capital of the world. Thank you very much, friends, for your patient listening. I mean, it's been a pleasure interacting with all of you. Over to you, Madhura.
Thank you so much, ma'am, for such an enlightening session. Really, really. And I'm sure all of us, the students, as well as all of us on the session, have learned something new out of this session. So, you have very elaborately covered, ma'am, the pathogenesis, the micro, macrovascular complications, the treatment, the holistic part of it, as well as the individualized part of it. So, really thankful for that. And now, ma'am, can we have the questions now?
Shoot, Madhura.
So, yeah. So this
Just wanted to say, Madhura,
yes, Shannon.
we really have, the talk was so nice. We have more than 10, 13, 15 questions, ma'am.
That's okay, Shalini. I will try my best to answer them, Shalini.
Sure, ma'am.
As long as you let me go to break my fast, till then I will answer.
No, no, you will always, that dua will always help all of us.
So, ma'am, first question is, ma'am, what is the best effective therapy combination for reducing nighttime hypoglycemia, and what should be the frequent screening protocol to reduce the risk of diabetic complications?
Okay. The best, see, the most important thing is for us to understand why this patient has developed nighttime hypoglycemia. So the first important thing would be for us to diagnose hypoglycemia in the night, whether you're doing it with a CGM or you're doing it with an SMBG. Because if you are, there are two things which can happen with nighttime hypoglycemia. Either the patient is having a low sugar and subsequent in the morning also this patient is having a low fasting, or sometimes the patient can have somogi, where the patient may have go into hypoglycemia and subsequently the patient becomes hyperglycemia in the morning, which you see as a high fasting and as a low postprandial sugar. If your patient is having nighttime hypoglycemia, two things you need to look at to reassess. One is the patient's lifestyle, which is very, very important and a contributing factor. For example, sometimes the patient may say, Madam, I was tired, I just went to sleep directly. Sometimes the patient may say that, Madam, today I decided to have only milk and go to sleep. All these things need to be kept in mind when you are evaluating nighttime hypoglycemia. The other possibility is that the medication which you are giving in the night is actually causing the hypoglycemia, be it your OHA or be it your insulin. If your medication is the culprit as far as the hypoglycemia is concerned, then you definitely reduce the dose of that medication. And preferably in patients who are going to nighttime hypoglycemia, avoid using medications. For example, avoid using sulfonylureas at that point of time completely. And if you need to use sulfonylureas, use shorter acting sulfonylureas. For example, maybe you can shift from conventional sulfonylureas to meglitinides, which have a shorter duration of action, which would again reduce this nighttime hypoglycemia, or just stop medication which can potentially contribute. If this patient is on insulin and you notice this patient goes into hypoglycemia, try to understand what time the patient is going to go into hypoglycemia. For example, your short-acting insulin onset of action, depending upon which insulin you're using, look at the onset of action, look at the peak of action, and look at the time when the action wears off. And according to that, at the time the patient go to hypoglycemia, try to understand whether it is the short-acting insulin or it is the long-acting insulin, which is the culprit, which could be either way. The last but not the least, if the patient is going to hypoglycemia, please evaluate for other causes. For example, evaluate for renal failure, evaluate for any deterioration of hepatic function, evaluate for hypothyroidism, also evaluate for Addison disease, because all these can contribute to hypoglycemia. As far as the second part of the question, Madhura, which you asked me, is how frequent the screening protocol should be. Initially, at diagnosis, for example, if a patient is any patient of type 2 diabetes, even at diagnosis, should be one screen for complications once the patient has become euglycemic. The reason I'm saying euglycemic, because the USCR is also influenced by hyperglycemia, for example. Hyperglycemia can cause a false positive elevation as far as the USCR is concerned. An infection can cause false elevation of the USCR. And that's the reason why once the patient becomes euglycemic, in a type 2 diabetic patient, should be screened for complications right there. Because as we all know, 50% of our type 2 diabetic patients are asymptomatic. And because they're asymptomatic, the patient actually sometimes comes to you with the complication. Patient may have been admitted with an acute myocardial infarction, for example, and then you diagnose the patient with diabetes. I'm sure you see this so often. So, and then depending upon what exactly you find as far as the complication is concerned, for example, if the patient has no complication, I would check this patient annually. If the patient has an initial onset of complication, I would once again check after 3 months. If the patient is not progressing, then maybe I would again make it every 6 monthly. If the patient is having progressive complications, I would check the patient definitely every 3 monthly, or even, for example, if the patient is having severely progressive, for example, maybe retinopathy, I would also evaluate the patient every monthly. So it will all depend from patient to patient as to what kind of protocol you would follow. There is no absolute fixed protocol that, okay, you would do it only this. An individual decision as to which patient needs to be monitored, how often is what you would decide.
Thank you, ma'am. That was very elaborate. Next question is, ma'am, I had seen a patient where HbA1c levels are normal, but the patient was hyperglycemic.
Yeah, that can happen just at diagnosis. For example, suppose you've diagnosed a patient with hyperglycemia, blood sugar fast. I mean, blood sugars may be elevated, but HbA1c, as we know, is a 3 months average. So it takes some time for the HbA1c to go up. So suppose this patient is just recently diagnosed with diabetes, I mean, just found to be hyperglycemic. And for example, it may be that you've done it for an annual health checkup. In an annual health checkup, you suddenly found the patient sugars to be high, the fasting PP and the HbA1c to be normal. This patient could just be having the onset of diabetes. And in that situation, it is definitely possible that this patient could be hyperglycemic, but the HbA1c can be normal. Other situations where your HbA1c can be normal, known patient of diabetic, but this would be where the patient has been doing very well, but suddenly that day the patient maybe has discontinued the medicine or has been a little non-compliant with the diet. That also can cause fluctuation, or suddenly fallen sick. All these things can cause fluctuation as far as the blood glucose goes, sorry.
Right. Coming to the next question. Hi, ma'am. What is your opinion about the new drug, Mounjaro, recently introduced and approved in India for treatment of type 2 diabetes and weight loss?
I think it's a very, very good drug. I think, tirzepatide is a dual agonist. It's a GLP, GIP-1 agonist. Very good drugs, do help with weight loss. But the only downside of the molecule is that, of course, the cost, which is something which is, significant, is something which we should keep in mind. And I wouldn't say a downside, but the other fact you should remember when we are using these molecules have to be used long term. You cannot use these molecules short term, because once you stop the molecule, then you will again have gradual weight regain. And this is something which we should keep in mind. Excellent molecules to use, but use it in the right context, use it with the right mindset, that these are long term molecules. These are not short term molecules to be used just maybe for 3 months, 6 months, and then stopped.
Definitely. Next question is, ma'am, is diabetes reversible if the patient is compliant and ready to follow our instructions?
Reversibility of diabetes again would depend upon number of factors. It would depend upon the function of the pancreas, for example. It would depend upon what is the C-peptide of the patient, what is the residual pancreatic function, what is the degree of insulin resistance we are dealing with. And if you have a patient with significant pancreatic function and with insulin resistance, which the patient is compliant and is willing to listen, as you said, and to follow instructions, yes, 110% diabetes is reversible. Again, a very important caveat over here is that all those precautions have to be continued. You cannot reverse diabetes, go back to your original lifestyle, put on back the weight, and say the diabetes has come back. So all these very important things require a lifelong commitment. This is similar to something which you would just do every day, day in and day out. Maybe sort of dedicate that 1 hour of your daily living to exercise, eat healthy, always be careful about what you are doing, because you need to understand that once you've been diagnosed with diabetes is diagnosed when the 50% of pancreas beta cell is already lost. So you are working with 50% beta cell, which you can definitely continue doing with a healthy lifestyle. So yes, 100% reversible, but very, very important thing is lifelong commitment.
That was very insightful, ma'am. Next question is, should we go for HOMA-IR for person with the multiple skin tags and family history of type 2 diabetes?
But to be honest, not required in every patient, because HOMA-IR is going to tell you insulin resistance. Even clinically, you can tell insulin resistance. For example, the patient has acanthosis nigricans, this patient does have insulin resistance. If definitely you want to document, please go ahead. I wouldn't say you should not go for it, but it is not mandatory to go for it for every person with skin tags and family history.
So again, here a personalized approach will help. Coming to the next question, why does diabetes occur at a young age and what are its salient causes?
Diabetes occurs at a young age because of some modifiable factors and some non-modifiable factors. Our non-modifiable factors are, for example, our genes. We belong to by the fact that we have Asian descent. I mean, the Asian descent, the Asian genes itself confer that increased risk of us having diabetes. And that is one of the reasons why in India you have younger diabetics, you have higher risk of complications. Those are the non-modifiable factors. The family history of diabetes, the fact that you can have the syndromic diabetes, you can have single gene diabetes, for example, MODY, which runs in families, is what you can see. The other issue that we can have with diabetes is also the fact that you need to remember that you can have mitochondrial diabetes also. So these are all the facts which you cannot really change. These are non-modifiable factors. What you can modify, which we can make a difference, is lifestyle. The increase high saturated fat, I do not like to quote anybody and say, okay, this kind of junk food is the cause, but all kinds of junk food, and it can be in any form of junk food, any kind of high calorie food, any increase of saturated fat, increase of our cola drinks, increase of calorie rich food, and most important, when this is contributing to your weight gain. So it is this with no activity which becomes actually the contributing factor. Bad sleep, stress. I mean, our stress also has, hit the roof with all the time, oh my God, looking at that perfect Insta picture of somebody else and living. I mean, we practically, Madhura, at this point of time, live in two worlds. One is the real world and one is the virtual world. And the virtual world creates a lot of pressure on people because you need to, at all points of time, have that perfect picture, the perfect smile, the perfect relationship. So all these kind of things are actually creating practically a stress situation for the younger generation, which is contributing to these problems in a very big way.
Agree, totally. Next question is, how does insulin resistance develops?
It's more or less similar, Madhura. A bad lifestyle with your genetic component is going to contribute to insulin resistance.
I think details Madam has explained in the earlier questions. One of the student is asking, ma'am, in my university exam, one question is there, how many types of diabetes are there? And he could not actually find a correct answer to this. So if you can.
There are actually at this point of time, the kinds of diabetes, the types of diabetes are broadening. The entire spectrum is still broadening. At this point of time, you have type 1 diabetes, you have type 2 diabetes, you have ketosis-prone diabetes, which is the type 1.5 diabetes, you have secondary diabetes, and you have gestational diabetes. And in this also, you are now adding monogenic diabetes. So the entire spectrum of diabetes is slowly and slowly broadening. It is no longer type 1 and type 2 diabetes, which we spoke about, or gestational diabetes, which we spoke about maybe 5 years back. The entire spectrum is broadening into all these different kinds of diabetes.
Another question is about prevention of diabetes complications and medicines for reduction of cholesterol levels.
Diabetes complications, Madhura, it would depend and divide again into microvascular and macrovascular complications. Microvascular complications are best treated with good glycemic control. One of the cornerstones of therapy remains good glycemic control, because with good glycemic control, you would be able to reduce the microvascular complications very, very significantly. As far as macrovascular complications are concerned, it's not only good glycemic control, it's your dyslipidemia, your hypertension, all these factors need to be controlled for you to be able to make a difference to macrovascular complication, that is your cardiovascular disease, for example, peripheral artery disease, as well as stroke is concerned. We all know that statins are the best medicines to reduce cholesterol levels. And if statins in isolation do not work very well, then you can use statins with ezetimibe. You have your PCSK9 inhibitors. So you do have a number of molecules which you can now use to reduce your cholesterol levels.
Right. So I think in the interest of the time, another couple of questions maybe we can take if you allow. So another question is, about the prevention of diabetes, and the question says, what are the best precautions as to not have diabetes in future generations if there is a family history?
It would be a healthy lifestyle right from childhood. The lovely chubby child does not look very attractive when the child becomes older. So it's a question of incorporating healthy lifestyle right from childhood. And there is data now which says that even the sugar which we are adding in milk, which we are feeding our infants, actually is detrimental to the health and contributes to the onset of diabetes subsequently. So it could be just that innocuous sugar which you think you're adding in milk for your child when they're infants, and thinking that that is going to benefit the child, is actually going to be detrimental to the child's health. So it is starts right from inception, right from looking after, seeing that the mother is healthy during pregnancy, she doesn't put on too much weight. It starts right from there, because we know about transgenerational imprinting. We know about the fact that an obese mother begets an obese child. So it is starts right from in utero, if you ask me very honestly, Madhura. So you have to prevent in utero to be able to make a difference as far as generations are concerned.
Right, absolutely. There's a question about recent
So
development.
I'll have to ask you to excuse me after 1 minute, huh, Raja?
Okay.
Definitely.
Sure, ma'am.
So should we take this last question, or
Last question I can ask.
ask about recent advances on islet cell transplantation and how to manage these cases?
At this point of time, islet cell transplantation is still in the research arena. We really do not have too much of new data as far as islet cell transplantation is concerned. Still a lot of research, but we've not been able to really get the kind of outcomes we hoped and we wished there were. So we hope that in the future we are able to really develop that branch of medicine.
Sure, ma'am. So, ma'am, I would, on behalf of Metropolis, I would like to thank you once again for your time. And this was a really, really enlightening session for all of us. Thank you so much.
Most welcome.
Thank you so much, ma'am.
Thank you, Vita.
Keep us in your dua.
No, definitely. Thanks, Shalini. Thanks, everybody. Thank you to everybody who's listening to me, who listened to us today. And a big thank you to Madhura, Shalini, and the entire backend team for being so nice and patient. And thank you, Metropolis, for giving me this opportunity. Thank you very much. Be offline.